And the idea of children in the emergency room is never a good idea. And at the end of the day, we hope to reduce the number of children relying on their mental health care or emergencies in the emergency room. But as those working in the emergency rooms and emergency services know, it is the point of access when there isn't other points of access, or you don't know where the points of access are. They're limited points of access. And so right now, statistically across the nation, and certainly in West Virginia too, the number of children presenting in emergency rooms across the country are skyrocketing, and it's also leading to longer boarding times and trying to get kids what they need. And it's ultimately a sort of symptom of
my end. I'm so sorry, but it kind of cut off on my end. It's probably my connection.
Okay, let me move a little closer. Because I think it's a point of frustration for families, a point of frustration for kids, a point of frustration for providers about how best to serve these kids. And so this is put together several key topics today just to kind of understand the reasons a kid might come to the emergency room, and to really truly, with the resources that we have, make it a positive experience, so that it's not just chaos central and triage central, but maybe to understand some very helpful things that can be done in the emergency room, or how to link kids to certain services that do exist in the state. Yesterday, I attended a pediatric mental health summit for the state, and one of the, it included pediatricians from around the state. It included some ED folks, DHHR, and mental health professionals around the state. And the striking thing to me in this meeting of the brains was how often people are not aware of services or things that exist to connect people to. So my hope today is to kind of bridge all of those topics. So we're going to start by reasons kids come to the emergency room, and to really understand what might bring them, and how to assess that, and how to think about that. Probably one of the most common reasons that kids get sent to the emergency room, these are not things I have statistics on specifically from my experience at WVU, but I would say that nearly 60 to 70% are probably suicidal thoughts, suicidal comments, cutting, harming themselves, or some other safety threat toward someone else that needs evaluated. And the thing about that is to understand the information that you have, because sometimes the details about that story vary from the party that reports it, and sometimes you don't have all the information. And so sometimes the child tells the parent, and the parent doesn't know what else to do and brings the child in. Sometimes the school identifies a concern and calls the parent, who may not know what to do. The parent feels that they need to bring their kids in. I've had kids show up on their own in the emergency room, having been escorted in an ambulance without an escort. And I really just have the child as the information, with very limited information from EMS. And sometimes DHHR brings them in if a child has struggled in foster care or DHHR care. Sometimes caregivers can change throughout the course of an emergency room visit as well. And so it's important to understand the context about the child room, what information you have. There's no magic ability to tell if someone's telling the truth or shying off information. As I said, I have not been taught to human lie detect. And people can change their stories. And so it's really important to try to gather all the information that you have. You have to know what the parent knows, what the guardian knows, what the school knows, and sometimes information gets lost. And so if you're on the outside of this from a clinic perspective, or an in-home service worker or a pediatrician, and you send a child to the emergency room out of concerns that you have, it's really important that that information be communicated so that we have that. There are kids that write severe suicide notes or have posted repetitively on Facebook, and numerous people have expressed concern. If we don't have that information, the child minimizes all of it, says it's not true, or says that there's all a misunderstanding, it doesn't make a great assessment. The more information we have from all parties involved, the better assessment we will make regarding that child's needs. Another major reason people come to the emergency room is aggression. I think it's really important to understand aggression and really important to not use the word aggression when taking chief complaints, because aggression means a lot of different things. Aggression is a symptom. It doesn't tell you much about what's going on. And so is it physical aggression? Is it verbal threats? Is it they punch someone versus they threaten to punch someone? Details kind of matter. Sometimes parents just bring kids because they're frustrated with defiance and less more severe physical behaviors. And so it's really important, and words matter with understanding that. It also really matters in how those words are used, because I will tell you that a kid that gets labeled with chronic aggression in the emergency room will probably never get placed. And that may not actually be the reason they need admitted. I've had to rewrite entire HMPs because the child's behavior was a trauma response. It wasn't purposeful, vengeful conduct disorder behavior, but the referring hospitals that we were trying to refer to viewed it as such when it was not the actual problem. So words matter in how we write about these kids. It also matters what the timeline is. If you write that a child has a long history of violence, but they haven't had an aggressive event in 6 years, you shouldn't put that in the referring provider. Kids tend to come with lots of baggage, and it's important we always ask, why now? What's the current symptom in the timeline? Because the whole baggage doesn't tell the story of what they need right now. It helps, and it's important to be there, but it's important we don't label kids with behaviors that happened years ago. Sometimes kids arrive in the emergency room with complaints of psychosis. I will tell you probably 80% of the time currently this is related to substance use that we're seeing. Specifically, cannabis has become a major trigger point for first episode of psychosis for a lot of kids. So there's often an element of substance use but they can present with really severe paranoia, command hallucinations. That's not always the case. Prime teenage years of 15 to 16, especially in males, are the first episode emergence of true thought disorders and schizophrenia spectrum disorders in youth. And so it could be a first episode of that that might present to the emergency room. And this can be very, very scary for families and kids when this occurs. Sometimes we get consulted in the emergency room because a child repeatedly comes in for unexplained physical symptoms. These can be things like non-electrical seizures to repeated GI distress. Sometimes kids present with continued chest pain, like that are panic attack or anxiety related, that may be bringing in lots of needed medical overlay, and they don't really need medical care. It may be an unidentified mental health problem. We see kids come in with ingestion, sometimes on purpose, sometimes not on purpose. And sometimes ingestions are complicated by safety issues. Were they trying to get high versus was this a substance use ingestion to try to injure themselves or harm themselves? That can be at play. I used to say I hadn't seen a lot of kids that actually needed detox, but as substance use rates have increased, we are seeing some kids that may actually need medical detox from opiates or alcohol. I did see a 17-year-old go into complicated withdrawals once. Usually this is something that you see more in adults, but it is not unheard of, and we must be mindful of those needs as well. Sometimes kids also present the emergency room for concerns about assaults on themselves from others. That could be things like first report of substance sexual assault, and that may require lots of coordination with others to make sure that forensic evidence is collected. Within the WV system, we have a SANE team that will work with those cases, and also local child advocacy centers. Are there any other reasons? Like, I know I have some folks from the emergency room. Are there other reasons that you think maybe I've missed that bring kids to the emergency room for psychiatric reasons? I can't see the chat for whatever reason. So let me throw, or Elizabeth, if something pops in the chat, let me know.
I'll definitely monitor that for you.
Okay. The interview is really important, and it's really important that all the parties involved, all that information is really collected, and this can be pretty time intensive. And sometimes information evolves. If I can only see the child and I don't have a parent or a caregiver or school report, it may delay care in the emergency room as we attempt to get that information or reach out or have to wait for a caregiver to come. But it really is important to get all those varying side stories, especially when you're doing safety risk assessments. You want all the information that you can. But it's also important to understand that that information changes. And it is very true. Someone may show up to the emergency room that was suicidal, that had a plan, was making an attempt. And in the course of connecting with people, telling their story, feeling the support of their family, their risk may change over the course of the time in the emergency room. So it is important to understand the time frame. And it is possible that a child that came in at first clearly needing admission, over time with support or an alternative safety plan or the engagement of safety planning, can really be more hopeful and have a good safety plan that may not require inpatient hospitalization. And so I frequently say sometimes time and engagement and treatment, even in the emergency setting with a caring individual or engagement with the family, can be incredibly therapeutic to change what they need. It's also important to understand parent anxiety because parents are really good at reporting what they see. They may be the best at describing behaviors and the details and what they found. But some parents don't understand that emotional information driving it. That could be because parent isn't much of an emotional thinker, doesn't know what's driving it. It could also be that the child's not telling them. And so I say, any parent that finds out their kids has injured themselves is going to be in an emergent state as a parent. They're worried about their kid. They care about their kid. It is an emergency to them. The backstory might not reflect the urgency that that parent feels when they first discovers it. And so part of engaging and treating and part of the therapeutic connection is bringing those stories together so that everybody's on the same page. So one of the things that I always talk about, I think I talk about this sometimes so blue in the face, but this concept of the antecedent behavior and the consequence, really understanding when you're getting behavioral information from sources, am I looking at all parts of it? The behavior itself doesn't tell you how to help somebody. So if a person's cutting, if they're suicidal, you can't help them just by that information alone. You have to know what led up to it. You have to know what the outcome or the hopes of those things were. I'm sorry, that's a phone in the back I can't turn off. The other thing is cognitive development really matters. And so you have to understand the cognitive level of your patients. A 5-year-old that says that they want to kill themselves or kill someone else is a lot less likely to be a true homicidal threat and has a higher likelihood of being parroted language or repeating something they heard. You really have to take that to the next step and say, well, when you say kill yourself or you want to kill someone else, tell me what you mean by that. You have to sort of understand their understanding of death. For children under the age of 7, they're often in a stage of magical thinking. They don't really fully embrace the concept of death or lethality or intent. And so their assessments could be very different. From about 7 to 11, kids get a little bit more logical, but they're often very concrete, often see only one side or one variable in a story. It's usually after age 12 where you'll see more of that abstract reasoning. You have to understand that context. If you have a child that has an intellectual disability, or if they have autism and have an intellectual impairment from that, you also have to understand their adjusted cognitive level. You might see a 16-year-old that functions more cognitively in their understanding at a 6-year-old level. You have to understand their language and their statements from their perspective at that level to truly interpret that. Does that make sense? Okay, so again, just going back to this idea of behaviors, really understanding what led up to it. So I'm going to use suicidality here as the example, because as I said, probably suicidal thoughts are one of the most common reasons a child will show up. So when you're assessing suicidality, you have to ask hard questions, and we're going to talk more about how to do that, but you have to get some context. How long has the child been thinking this? A child that has been planning a suicide attempt for weeks, that snuck out of the house to buy the materials they wanted to overdose, that waited to take the ingestion when they knew their parents were going to be out and they'd have hours of time, is a very different child that presents with, I just found out my boyfriend broke up with me and I felt that way in the moment and I said that, but I don't feel that way now. It was just something that occurred to me in the moment, a fast reaction versus that I had planned. So you have to understand what led up to it. It's also important to understand what comes after the behavior. A suicide attempt, an actual attempt, is a good example of this. If a child wakes up following a suicide attempt that was not successful and they immediately say, I am so glad to be alive. That was the stupidest thing I ever did. I felt alone. Everyone now, I realize, cares about me. My room is full of my family and I feel so much better knowing that they love me. That's a very different child that wakes up from an attempt and says, I wish I had still died. So it's important that we understand that story. The other behavior that's really important to understand is aggression. Aggression is usually the reported behavior, but understanding the context of the aggression really matters too. Again, a child that is trauma triggered, that gets reactive and aggressive, or a child with untreated ADHD who forgot their medicine that has aggressive event, is very different than a child that hits to obtain something that they want, or hits to exert power, control, or over something that's premeditated. And you have to understand that behavior in all of those contexts. All right, so just one of the things that I think is really important, and I had a teacher yesterday at that conference tell me often they do suicide screenings, but they want to always learn more about how to be more therapeutic about that and how to understand it. And so it's really important that we ask kids about suicidality. But after we get a yes or we get information from a parent, it's really important that we keep going. And I often tell medical students, that's just the first question. Asking more, understanding more really helps put it in context. So the first thing to say is, we're really glad you told us. I know these things are really hard to talk about. Could I ask you a few more questions about this? And you have to get into the details, and people will tell their own stories with this. So you want to know how often they've had their thoughts. I ask folks how close they've gotten to acting. Have they acted? What's the closest they've gotten to acted? What kept them from acting on those thoughts? You may have a child with no risk factors, no attempts, but I've asked that question before. How close have you gotten to acting on those thoughts? And they were holding a loaded gun to their head playing Russian roulette. And so that's a very different story than a child that may have had other behaviors. So you want as many details as you can. One of the things we do know is that past attempts do reflect higher risks, and self-injury, although in its own right, may not reflect active suicidal ideation. Having a history of self-injurious behavior does increase the risk of future suicidal ideations. But it's also important to understand that some children self-injure for reasons other than suicide. And those are very complicated things. So some children cut for emotional release, control. Some kids feel numb and they will cut to feel something. So even in the context of self-injury, I'll often say, well, tell me about the cutting. Do you like the cutting? Does it do something positive for you? Does it help anything? Do you dislike the cutting? You know, when you're cutting, are you wishing you were dead, and linking them together? It's also helpful to ask about other symptoms that might be going on with suicidality. I think lots of people are sort of prone to screen for anxiety and depression nowadays, and hopelessness, because we often think of suicidality as a mood disorder. But one of the things that's become very, very clear in the evidence for children is that impulsivity and often untreated ADHD has super elevated risks for suicide attempts as well. And that's the idea of not thinking or being able to problem solve and have executive functioning at a level it needs to be to work through difficult problems. That lots of times impulsivity will lead to attempts and completions in children, and they have no history of a mood disorder. And so that is equally an important symptom. Substance use, acute stressors, those can all exacerbate that. But also part of this assessment is also understanding the flip coin of that is not why do you want to die, but tell me about the supports in your life. And this is where when you're talking and interviewing a child, you have a tremendously positive impact. You came here today, you told someone, tell me about the people in your life that are supportive. Tell me about the reasons you don't complete. What keeps you living? What keeps you going? What are the things that you still have hope for? And that can be a really therapeutic point of helping people plan. And sometimes, again, depending on the point that you enter the interview, sometimes with kids, as I'm doing these assessments, they're surprised at how much support they've gotten. You know, I told my mom, I told my school counselor today, that's how I ended up here. I didn't know how much they cared or how willing they were to help. People actually did listen, and kids can feel a lot better sometimes before they get to the official interview based on how they've been responded to along the way. So sometimes the patient interview is easy than the guardian interview with kids. Sometimes guardians are just as scared or more scared than the child, because they're not only worried about their child, but they're also very anxious and overwhelmed and may not feel confident in their own skills to keep their child safe. So you have to also sort of assess their comfort level and ability to talk to you about that. And that's also a wonderful opportunity to support parents' strengths and provide education to the parent, because ultimately if this parent is also going to be a huge important person in how to help that child. So as you conduct the interview, you also want to not just think about collecting information, but being therapeutic with it and making a really good risk assessment. And so part of the goal, and there's some data that is coming out that shows that almost 75% of people that might come to the emergency room might actually be able to be stabilized by therapeutic interventions in the emergency room and might not even need hospitalization, especially for suicidality. So good therapeutic and supportive interventions and connections to services, a lot of these people may actually be better managed with outpatient, community-based close follow-ups. And so part of the next step after the evaluation of the risk is to really assess what is doable to get these folks and identify the supports, community, and linkage to services that they need. All right. So you don't have to remember all of this, but this is a fabulous resource. This is the one of the screening questionnaire sets that has been established at WV hospitals lately as a screener for suicidality. It specifically screens for suicide. Previously, we had been using depression screeners, which, as I had mentioned before, often miss other reasons why people may have suicidal thoughts. But there is a whole toolkit, and this toolkit is designed for non-mental health providers. It has some walkthrough steps on how to ask, what to ask, in a very therapeutic way that can be adapted by multiple providers, multiple clinicians, nursing staff, and otherwise that can be used. So once the screener is conducted, you'll get a positive result. There actually is a step-by-step questions that you can go through. So again, just remembering this concept of be the one to be a helper is asking. It really is important. And I say this because I know it's a hard question to ask, but you cannot put the idea of suicide into someone's head by asking. You can do a lot of harm by not asking, but you can never really do harm by asking someone. So you want to ask. You provide support by simply keeping them safe and giving them a therapeutic space to feel heard, listened to, acknowledged. And then as you've done that assessment, help them connect. The next part is determining what they need and staying connected and linking them to services, which has been the ideal plan. I'm going to give you an update on that suicide prevention lifeline number here in a minute, because it's gotten a whole lot simpler. But there are other ways to get them connected. So that number was the National Suicide Hotline, and actually as of July 16th, so 3 weeks ago, our state, along with many others, adopted some of the federal legislation to move to 988 services. So this is like the mental health emergency line comparable to 911. And so 988 is actually active in our state, and its resources are working and being directed through First Choice of West Virginia, which is the same organization that's working on a child mental health crisis line that I'm going to show you in a minute as well. But it is really designed to try to get people that need emergency mental health support what they need. My understanding is the old number still works, but I think they're being covered by the same entities in most states. I don't know when and if that old number will be phased out, but 988 is active in West Virginia. Other things that are important in the conversation and the safety plan is really to provide an environment of safety. With children, most access to lethality and death is related to impulsivity and being able to reach something when the thought occurs. And so it may seem overly simplistic to tell families, you really need to try to get those firearms out of the house. You really need to make sure the guns are locked up and the bullets are kept separate and your child doesn't know the combination. And I can't tell you how many times parents think the kids don't know there's a gun in the house, but they actually do know. And it's sometimes shocking. And I'll sometimes ask the kid, do you have access to a gun? I get a very different answer sometimes from the kid than the parent about that. So it is important to ask, but just removing access can buy people time to reach for help instead of a lethal means. The other thing that's probably really important is to lock up over-the-counter medications and prescription medications. And I tell people to go get a lockbox. Sometimes with kids in the emergency room, if the parents live close by, I'll say, go lock it up now while we're waiting to get your follow-up and come back, because it's that important. Most overdoses that are lethal in kids are Tylenol. So even things that may seem more benign to parents can actually be the most lethal, but blood pressure medicines and Tylenol can be incredibly problematic for overdose risks. So having them lock those up really matter. And what I tell kids is, if you've had suicidal thoughts before, the process of getting engaged in treatment, they're not going to go away. And I tell right away. And I tell parents that too. You're not going to just walk out of your first appointment with a therapist or a psychiatrist or the emergency room and not have them come back. Chances are they will come back. Hopefully they won't be as strong because you're going to have some skills and you're in a safer environment. But it's actually important as part of that safety plan is when they do come back, what can I do? Sometimes kids will say, I just can reach out and sit with someone and not be alone. I'm going to do better. I'm going to tell my mom, or I just need to be in a quiet place and have someone check on me. And so it is helpful to sort of problem solve people with that. And that's often part of the safety planning. It's really important to use this as a point of communication with children and families, because what will happen is if you don't prepare the parent's going to go home paranoid and worried, and you're going to get a situation where the parent is literally staying up all night watching every move. I'll have parents try to sleep with their children or violate their privacy, and that can be equally not helpful to some teens especially. So it's really important that in that safety planning process you say, you're going to drive each other crazy if you don't work on a plan. Can we make time every day to talk? When's the best time for you guys to do a check-in? Is when you came home from school, how'd you do today? How were those thoughts? And if you need anything, this is how we urgently find me or urgently let people know. And so that type of support, or just knowing there's going to be a check-in, can also reduce some of those challenges. One of the things that's important that I think is really not well understood outside of behavioral health is that psychiatric levels of care can be very different. And I think sometimes our efforts to reduce stigma regarding mental health is part of that education about what exists. But I love my state of West Virginia, but I sometimes think part of my Appalachian heritage sometimes is that we have had a little bit with families sometimes this idea that sending my kids away to get help is better than the help that you can have with your family, and that family-based treatment and trying to keep kids with their families can be far more helpful and has way better outcomes than splitting that family care, unless there's an emergent concern regarding the parents' abilities. So at the very top is acute inpatient psychiatric unit. The WVU system only has one 10-bed acute adolescent unit in the state. So the reason I say this is you have to understand how an inpatient psychiatric unit is quite different than what experiences. One, it does not allow parents to be there with their child. So if the parent doesn't live nearby, it could be for some kids the first time they're ever away from their family, and that can be fairly traumatic to do, both for the parent and the kids sometimes. It is locked. They do not have access to school on site for those acutes. It's a pretty intensive level of treatment. It's group-based with some individual and family components, but it is the highest level of care. And people that are far from inpatient hospitals, or if our inpatient hospital is far, sending kids 3 or 4 hours away to hospital could limit some of the success they could have with their families. So again, unless there isn't an alternative, acute admissions for suicidality really should be about kids that have a plan, that can't safety plan, that have an urgent need that can't be reassessed and into outpatient treatment. A step down level of care from acute are this idea of like group homes or residential psychiatric treatment facilities, which are a little bit different. A psychiatric residential treatment facility is usually a month's long program, usually 6 months, 3 to 9 months, depending on what it is. These often are out of network for commercial insurances, and these are very long processes. And this is often the point of lots of frustration currently in the healthcare system, that kids come to the emergency room. They don't need an acute bed, they need a residential bed. This could be in regards to suicidality, kids that have recurrent suicidal ideations that have not been able to be maintained, but finding a long-term treatment facility is very time intensive. There are systems where you have partial hospital programs or day hospitals where kids get 6-8 hours of treatment daily and then go home at night. We do not have those in North Central West Virginia. And then we have this idea of augmented or intensive outpatient services that can involve a lot of things, but often rely on using health services in behavioral health that may be outside of the WVU system directly, or in different services. And I think this is the area I learned yesterday. Lots of people in pediatrics and the emergency room know very little about, and it's important that we continue to connect people to the services. I'm going to touch base on those a little bit here in a minute. The idea of a regular outpatient visit. is often just the idea of maybe weekly psychotherapy, a monthly psychiatric visits. And for a lot of kids in crisis, that may not be enough. And so you have to make a decision about what they need before they leave. And again, here's a picture I stole from Jessica Belt that we presented yesterday, sort of what an ideal and needed continuum of care is, so that we can offer care at every level of behavioral health. And I'm not going to spend some time on this, but for our state, there's still some significant gaps in this system of care. And they could be gaps regionally, like they may be harder to access. They could be gaps over the whole state as well. Right now, one of the challenges in West Virginia are workforce issues, and that workforce limitations make it very challenging to build out the whole spectrum. So how do you decide if someone that comes to the emergency room really needs that acute bed? And so, as I said, when we do those suicide assessments, we really try to understand, is there an intent? Is there a plan? How is the relationship with that parent? Is there any amendable safety planning that can come up with the least restrictive environment to be helpful to this kid and not have to separate them from their families? If there is no safe alternative, if a child cannot participate in a contract for safety, if it's just too high risk, they're still actively planning to complete, they should be admitted. Kids that are acutely psychotic, especially with command hallucinations or mania, not sleeping, agitated, aggressive, they may also need admitted. If they really require detox, they may need detoxed. Sometimes kids present with some type of unspecified adjustment or crisis. I think for our population right now, the biggest category of this is often trauma-triggered kids. They get so dysregulated, they may have an intensive worsening of trauma responses and flashbacks that they just cannot regulate themselves, and it can be very impulsive, may need admitted. And then homicidal ideations are always kind of complicated in psychiatry, because definitely some are related directly to a mental health disorder. Sometimes kids are making threats to have more verbalized control or power. And so those are hard decisions. No one ever wants to really think about a child that might be experiencing more of like a conduct disorder, or more of a antisocial sort of disorder, but it does happen, and it's sometimes harder to split out. But the homicidal risks have to be evaluated right alongside of the risk. And I think sometimes this is really where that other information is really important. We definitely are seeing increases of kids being sent to the emergency rooms from schools regarding risks or threats for like school shootings. It's very difficult to evaluate that risk if you don't have that information about why. If we don't, as providers, don't have the details about where that fear came from or what was seen on Facebook, we're not going to do a good job with those assessments. Sometimes it's also hard to understand that there are a lot of chronic sort of things. Kids with complex trauma, chronic behavior problems, ADHD, chronic aggression may not be best served in acute or residential facilities. And although they really are struggling, it may not be the best level of care. And recommending inpatient just because the parent's exhausted, or for respite, or or because the parent doesn't want outpatient can be challenging. And so, it's always hard. You always want the child, the parent, and the team to all be on the same page, but sometimes parents are scared, and you have to work with them as well. But it just, fear alone isn't a reason to put a kid in the hospital if it's not really justified, because we still are trying to keep them at the lowest, least restricted level of care, but still keep them safe. And for a lot of people, it's a lack of understanding about what is available in the community as well. So this is a reference plug to realize that this doesn't have to be done in a vacuum. There are evidence-based instruments that can help you decide what level of care a child needs based on all the information we have. Does this child really need acute? Do they need partial? Do they need intensive outpatient services? Now, the challenge with this instrument is, although it's very evidence-based and a good option, we don't have sometimes access to all the levels of the care in here. All right, so the other thing I want to just make sure everyone's aware about, following the Department of Justice report, it was 2016, the state has put forth substantial resources to try to improve and expand mental health access within our state. And I think this is an area that's been poorly advertised to realize how much they have done. And so I want to share with you the resources that exist. The most important number, Dr. Mullet calls this the bat phone number, but this is the 24/7 crisis and emergent hotline in the state of West Virginia. It's the same one that adults use to find substance use services, but has a dedicated child resource center. I've called this phone number. It's 1-844-HELP for West Virginia myself. They are the really knowledgeable people. They maintain a database of all the providers, services. They have even legal services to connect people to school-based services. It's a very helpful number, but they also help people get to where they need. So they can connect people directly to the suicide talk lines if they need it. They may tell people that they need to go to the emergency room, or they could send mobile crisis directly from the phone call to their house if it's urgent. But they're a wealth of information trying to connect people to providers. They've been helpful, especially in areas that I don't know where the resources is. I've used this number to connect kids to therapists, especially in counties where I may not know who those folks are. So this is an amazingly helpful number. You don't have to be a provider to call this. Parents can call this directly, but providers can call it. It's the one-stop shop, and they are a vast knowledge of information. Part of that, I haven't changed it yet, Emily. I need to change this. I don't know if you changed the number of the mobile crisis unit, because we're not calling it United Summit Center anymore. So I don't know if the crisis team number has changed, but we have a statewide mobile crisis. So this is like a mobile response team that in an ideal sort of understanding would be able to be dispatched and get to a member within an hour to provide mental health. And this service team is being linked with the 988 number to help with suicide outreach and emergency response as well. So this is statewide, and every county has access. Mental health wraparound is a way to kind of intensify services in the community. It doesn't have to just be at risk for out-of-home placement anymore. That was some of the initial things, and that's been superseded sometimes by kids on the CSED waiver, which I'm going to mention next. But if you're having a kid that needs more intensive in-home services or services at school, the wraparound may be able to provide family and individual services to a family through this project. I also wanted to say, especially for emergency rooms, if you are planning to dispose someone to the community and you think they still need mobile crisis or may have a more urgent event, the mobile crisis teams will actually connect with people in the emergency room. We've had them come in person to our emergency room. They could connect via tele. I've had families that are afraid to leave the emergency room because they're worried another event's going to occur. This is really where you can use those multiple crisis teams as kind of a warm handoff, so they can meet the families and plan the follow-up from the emergency room, because no one comes to the emergency room between the hours of 8 and 4 when you can make them an appointment. It's after hours, and they're worried they're not going to get that call. And this can be a really nice warm handoff to meet people and feel a little bit more connected. The state has also created something called the CSED waiver, which is a waiver program for children with more serious behavioral health disorders. And this is something that is for very high utilizers of need. These are kids that are really at risk of being removed from their families, or have had multiple admissions, or have had multiple emergency room visits, or really in crisis and they need the whole thing. This is the Cadillac of what the state's offering. And kids that enroll in this will get case management, they'll get community transitioning, they can get school-based services, respite services for the family, in-home support. The insurance that manages this is Mountain Health Promise, so they get case management at both at the insurance level to connect people to their communities, specialized therapy, and often liaisons with DHHR. There is, if anyone wants it, there is a backdoor sort of a referral form online for providers to make direct referrals to this program, but parents can also apply directly. And actually the 844 Help for West Virginia number will help connect parents as well to that waiver program. Right now, when they apply for the waiver program, it's processed. The child often gets a needs assessment or even testing. And it's running around 30 days to completion and decision right now, which is pretty good. I will say that I think all of these services, mobile crisis, CSAD waivers, are all substantially underutilized right now. And a word of advice that I've learned is I often ask families instead of suggesting these things, because one of the things I have noticed is some families are afraid of anything related to the state coming into their house. It's this idea, oh, if they come into my house, they're coming in to take away my kids. And that is absolutely not the goal. The absolute goal these are all programs to keep kids in their families and in their communities and not be sent away. But there's a lot of education and families can have some fear about that. So often spend it, and this is very client and parent sort of your wish driven. So, they're not going to make you do anything that you don't want in terms of care, but sometimes I'll lead with what kind of support do you think you need? And they're often describing these services, and then I use that as a leeway to kind of sell it to people. There are a couple other collaborative options just to be aware of. This is a Psychiatry Echo, which we're on right now. And this is a place we can talk about those kids, talk about resources. The WVU Mars line is also a referral 24/7 to talk to a psychiatrist. That's not always a child psychiatrist. It could be referral to our case management during the day or an on-call psychiatrist. We also had a PALS line, which I've done an echo on before. Right now, unfortunately, because of my availability, this line's actually on hold, but we're hoping to be able to reopen it soon. I'm almost out of time, but I've asked Elizabeth and Mithra to send you the article. The final thing I wanted to touch on was about handling aggression in the emergency room. And there is a wonderful article called the Beta Study, which I've asked them to send out. It is an enormous resource, I think, for people in an emergency setting to think about medicines for kids or how to address it, that we'll send to you. And I was going to highlight a few quick things. My first key about this is medicine should kind of be the last resort. I know sometimes people go to the emergency room to get emergency medicine, right? That's its name. But most of the management of aggression in kids comes from us as caregivers and the environment we create, especially severely traumatized children. The environment, the sounds, the noises can be incredibly triggering and dysregulating to them. And so environment matters, how we approach people matter. De-escalation techniques are always important and can go a long way to never needing the medicine. But sometimes medicine is needed, and it's a helpful article to really look at what are the goals of medicine, what medicine should I pick, what are we trying to accomplish? And so like I said before, aggression and agitation is really a symptom. You can't assume what someone's diagnosis is or etiology just based on that. So you have to go looking further. It's like a fever of unknown origin. What is causing this? And if you can have some idea, oh, this seems to be a trauma response, or this is untreated ADHD, or this looks psychosis, can really help drive your decision-making about what you choose. Because the goal of the emergency medicine is to target the underlying cause if we can, so that we get this child stabilized, because sometimes they're so aggressive we can't even assess them. So we got to get them stabilized and point to rapidly assess and ultimately treat them. And this, I think, is the hardest thing of all, especially in littles. How do you find something that calms them down but doesn't snow them? Because if you knock them out, they can't give you any history, and then you're stuck. And then you extend your wait in the emergency room. And then I come down to the emergency room and I'm like, well, they're asleep. I can't assess them. I don't know anything. I try to get what I can, then I have to come back. So you want to calm them just enough, but not too much that they fall asleep. And there's no magic algorithm, and each case may be quite different. So these are just some guiding principles. Sometimes you have to know what you have access to, what's on formulary at your hospital. Is this child going to take it orally? Do they have IV access? Are you going to need to give an injection? You know, is it going to interact with something they've already taken, or if they've ingested something already, is it going to have an effect? And you want to know about their overall health status. It's also really helpful if you know what's worked before, you know, and be preventative. You know, if you have a kid in the emergency room with untreated ADHD and they didn't take their daily stimulant, sometimes giving them their daily stimulant is a far better way to calm them down quicker than to try something new. So, and that happens a lot more than people realize. Parents run out of their medicine all the time. They'll see an increase in behaviors. If you can sort of put it into one of these categories, it can help you link sort of to choices. So delirium, truly medical, they're waxing and waning, they're having a sensory change. Is this substance use? Did they ingest something? Did they do some stimulants? Can be helpful. Is this autism? Do they have a developmental delay? Is their behavior coming from a lack of understanding communication? Do they have some clear diagnosis? Is this catatonia? Do they have ADHD? Are they anxious? Is this a trauma response? Are they manic? Are they truly psychotic? That can really help guide you. And this is this big messy table that's going to be in this this article I give you, so I won't read it to you, but it's literally like a pathway of the best choices if you can sort of start categorizing them to sort of follow, and it gives you ideas on what might be the best thing to try. These are the ones that are most commonly used in different classes and the forms that they come in. And then this is the chart that gives some of those pediatric doses and some things to just be aware of regarding their age or how it's metabolized, that can be incredibly helpful if you've never had a chance at looking at one of those before. All right, 5 minutes to go. I will pause and take questions.
Thank you so much, Dr. Swagger. As always, you always do such a wonderful job presenting, and it's just so much great information in there. So we appreciate it. Carmen did chat in a little bit earlier when you had the phone number. So she was saying my cell phone provider sent me a message about the new phone number during your presentation. So that's exciting. Any questions, comments from the group? Or Carmen, if you have any other comments on the Kayla, you're muted.
Oops. No questions. I just wanted to say hi to Lauren and say that I miss her. And thank you for this presentation. It's fun getting to see you back in action. Not that you left action, but me getting to see you.
Good to see you. Yay!
Yeah, thanks for presenting. I know you and I talk a lot with being in React, the process of hospitalization, because we see it so much, but to get it all kind of like streamlined and kind of knowing like, okay, like, you know, how can I, at the level that I'm at, how can I kind of like intervene best? Mm-hmm. So I appreciate you.
So good to see you.
Yeah, I gotta run, but good seeing you.
Thank you, Kayla. And Jordan commented in as well, saying she doesn't have a question, but just mentioning that it's super informative and interesting, and she learned so much. And thanking you, Dr. Swagger. And Anastasia also saying great presentation. Love the ASQ and what questions to ask resources. Thank you all for chatting those in. Any other comments, questions? And we will be attaching your PowerPoint in the recap, Dr. Swagger, along with that, the data studies. So I'll put that PDF in there as well.
All right. Good to see everybody. Until next time.
Thank you all so much. Thanks again, Dr. Swagger. Only announcement, next session will be on August 17th, and Stephanie Laura will be presenting on treating noncompliance in pediatrics. So we hope to see you all next time. Thank you, everyone, and have a great week. Take care.